up to 2 doses 6 months apart. It is immunogenic in adolescent, whether the period or the frequency of giving the vaccine. Antibody level remained above the protective threshold across antigen for up to 7.5 years. And 4C mean B demonstrated an acceptable safety profile in adolescent during clinical studies. While rates of solicited reaction were generally higher with 4C mean B than placebo, no safety concern were identified. So you can see here the difference between placebo and different side effects like the pain, erythema, and duration. But again, it cannot stop you from giving the vaccine if you compare the benefits and risk. For more information, please refer to the prescriber information or contact GlaxoSmith via GCC Median Information gsk.com to report adverse event here and to report quality complaint associated with the use of GSK.
Thank you very much for your presentation, Dr. Muhammad. I will be sharing. Your presentation, mashallah, contained everything, and you left a little room for me to add. But inshallah, we go ahead with again continue to talk about the MenB vaccine. Can you see my presentation? Yeah. So update on meningococcal vaccine guidelines.
Yes, Doctor. Go ahead.
So meningococcal disease management and prevention with a focus on high-risk population. These are my disclosures. Okay. So meningococcal meningitis is, as known, a deadly global disease. The invasive meningococcal disease can cause serious illnesses, deaths, or sequelae. In 2017, in the EU, 3,221 cases of invasive meningococcal disease, including 282 deaths were reported. In the same year, in the US, 350 invasive meningococcal disease cases, including 45 deaths were reported. So you can see this is a disease with high mortality, without treatment, up to 50% mortality rates, and with treatment, 5 to 10%. Invasive meningococcal disease is an infection that does not cause large-scale epidemics, thank God, but it's fatal and has severe consequences. And some 30 years ago, when I started off in pediatrics, and Dr. Muhammad showed some data from Egypt in the 1990s, it was a dream to have any sort of vaccine for meningococcal disease. I used to see a lot of infants and children coming in with symptoms of meningitis, and when we did the lumbar puncture, you just know it right away from the CSF. So why is it that infants and adolescents are at risk? So by age, the age group we move on to the adolescents. This is the age group with the second highest incidence of invasive meningococcal disease. Immunity again is waning. There is high carriage rates among the population. Sometimes there's a lot of crowding conditions, and their behavior is more risky. So what do we have in guidelines for these populations? So I'm going to shed a light on the DHA, CDC, and NSH vaccination guidelines for these populations. And here we start with the MOH. And MOH has a guideline for the meningococcal ACWY. First dose given at 12 months, the booster 10 to 11 years, which is grade 5, and 16 to 18 years, the second booster, which is around grade 11. And that's for the ACWY. If we look at the DHA guidelines, they've added here the MenB. So adolescents and young adults ages between 16 and 23, preferably 16 to 18, who are not at any extra increased risk. This is only by their age group, so they don't have any other risk factors. It's recommended that they get 2 dose series of MenB, the Bexero, which is has 4 components, and the 2 doses should be at least 1 month apart. Okay, and the Bexero is the only one available in the UAE. The MenB vaccine it can be administered with the ACWY vaccine if indicated, but we use a different anatomical site, like this in one arm and the other is in another arm. How about the CDC meningitis vaccination guidelines? So this one has the same group, the infants and the adolescents, and the high risk, but I will talk about the high risk later. So again, they recommend the two types, the MenACWY, and they recommend the Sero-B meningococcal or the MenB vaccine. All 11 to 12-year-olds should get the MenACWY with a booster at 16 years old, okay? And then the teens and young adults, 16 to 23, may also get the MenB vaccine. The CDC also recommends the meningococcal vaccine for children and adults who are at a higher risk, and I will be talking about them later. The NHS actually, they start early with the MenB. They start their first dose at 8 weeks, which is 2 months, and the second dose at 12 weeks. And then they give a third dose after the first birthday. So 2 months, 3 months, and 1 year. And the MenB vaccine, the 4C MenB, is the recommended vaccine for the routine infant immunization program in the NHS. So now we talk about our high-risk population groups. Who are our high-risk population groups? So all doctors, not really, only those who, mainly the microbiologists, who routinely work with the Neisseria meningitidis isolates. And anybody with impaired immunity, like those with asplenia or complement deficiencies, and we're going to talk about them as well. Again, like Dr. Muhammad said, military personnel, and why is that? Usually they have high carriage rates, they exposed to different diverse serotypes. There's a lot of traveling sometimes, they live in crowded living conditions, and the highest risk are the new recruits. And also we talk about the travelers to the endemic regions and pilgrims who are in close proximity in large numbers coming from different parts of the world, like those attending Hajj and Umrah. So this is a study about the clinical data on the use of the 4C MenB in high-risk groups. Mainly this focuses on the complement deficiency or the splenic dysfunction. So why do individuals with complement deficiency or splenic dysfunction have an increased risk of invasive meningococcal disease? Basically, the complement system is first to respond to kill the bacteria and activates using 3 pathways: the classical, the lectin, and alternative pathway. There's also the late terminal pathway, which is a subsequent mechanism that leads to bacterial lysis. Patients with complement deficiencies have a greater risk of contracting the invasive meningococcal disease. And vaccination against invasive meningococcal disease is recommended in patients with complement deficiencies. We have 2 studies that have investigated the use of 4C MenB in children with these conditions. The Martinon-Tor-F study in 2018 and the Van der Burg in 2019. The first study of this is for the safety and immunogenicity of the 4C MenB in children with complement deficiency or splenic dysfunction. And the second one was for the effectiveness of the vaccine. We are going to shed a little bit more light about the study. So what was the study setting and the participant? So the study took place in 5 countries: Russia, Poland, UK, Spain, and Italy. Number of sites were 18, and it took place from May 2014 to March 2015. The study participants were children aged 2 to 17 years old, enrolled into 3 groups: the complement deficient group, the asplenic or the splenic dysfunction group, and healthy controls. Excluding criteria for the study: anybody who had previously had MenB vaccine, or anybody who acquired invasive meningococcal disease in the year prior to the study, or anybody was on antibiotic treatment within the last 3 days before enrollment. So as we can see here, the children between 2 to 17 divided into 3 groups. The number of participants was 239, 40 of the complement deficient, the splenic dysfunction 112, and the healthy 87. What they did in the study, they took their blood, they tested the blood at 0 and at 3 months. Okay, so at the beginning of the study and then after the 2 doses of the vaccine. And the vaccine was given at the beginning of the study, 1 dose, and the second dose at 2 months. And the the outcome, the primary outcome was for the immunogenicity analysis, okay, for the 4 strains, for the factor H binding protein, Neisseria adhesion antigen, the porin A, and the Neisseria heparin binding antigen. Additional results were for the percentage of subjects with serum bactericidal activity assay using the human complement, and to check for safety and tolerability. I'm going to go to the results. So this was the use of the HSBA assay with exogenous or endogenous complement. So they used both. And this is the summary of results. So following the primary vaccination, which is the 2 doses, there was an increase in immune response was observed in all 3 study groups. Children with asplenia or splenic dysfunction had similar immune responses to the healthy control group. So those with splenic dysfunction benefited the most, just as the normal healthy control group. Those who benefited a bit less were the lower immune responses were reported in children with complement deficiencies, particularly if endogenous complement was used for the HSBA. Line was observed. The significance of lower immune response observed in complement deficient children, including those on eculizumab therapy, should be investigated a little bit more. But there was no safety concerns identified for any of the groups. And 4C Men-B is immunogenic in children with asplenia or splenic dysfunction. But it was safe for all groups. So what's the recommendation for kids with sickle cell disease? People with sickle cell are also vulnerable to infection from bacteria, Neisseria meningitidis, and the recommendation are for the 2 types of vaccines to be used, the meningococcal ACWI and the Men-B. The difference here is that they don't just take the initial dose, which is the two vaccines. They should receive a booster at 1 year. It's some guidelines. They receive a booster at 1 year, and then every 2 to 3 years after that, because it's a continuous condition. And especially in countries don't have routine Men-B in their childhood vaccination, we need to shed a light on those. And I believe there are few cases of sickle cell disease that we see here in the UAE. Okay, Dr. Muhammad shed a lot of studies about the mass gatherings and the pilgrimage. And this is a recent study. I think it was not mentioned in Dr. Muhammad's presentation because from 2025. But there was, by May 2025, 51 cases were reported, including secondary and exported infections had been linked to the outbreak of meningitis. So that tells us there is a lot to be done still. And I think from clinical practice, it was mandatory before for meningitis ACWI vaccinations before going to Hajj and Umrah, and then it's been lax since COVID, with on and off sometimes recommend it's a must or not. But as healthcare providers, we should vaccinate our patients. So when they come to me actually in the clinic and they ask, do I need to take it? I explain the benefit of the vaccination to them. And I tell them, forget about the recommendations, if you needed to travel or not, this is what you actually need. And this is, I think, our role as healthcare providers to explain to the patients the benefits that they will get from being protected by the vaccine. So again, here, what is already known, we know that Hajj and Umrah are a place where there's a lot of gatherings and there is increased risk for meningitis infection. And it's safe to be given to anybody traveling above the age of 1 year. Vaccination guidelines for high-risk groups continued. So here, and this is a DHA, very lovely table. Talks about different groups and the recommendations for meningitis, ACWY, and for Men-B. So as you see in pregnancy, it's not routinely given. But if this pregnant lady is going to Hajj or Umrah, or she's going to be in a condition, it can be discussed and it can be given. Either meningitis, ACWY, or Men-B. And it has to be, it's like a decision that is made. It's not a routine, but it can be given. In cases of diabetes and adrenal insufficiency, it's an optional vaccines for anybody above the age of 18 for both the ACWY and for the Men-B. For cardiovascular disease, there's no recommendations as of yet. For chronic, no extra recommendations. Chronic liver disease and alcoholism, again, it's like the diabetes, routine vaccination for all ages, more than 18 years, for both of them. For HIV, it's the Men ACWY, it's routine for ages above 18. And for the Men-B as well. No, this is excluding HIV. This is for immunodeficient. For HIV, the ACWY is recommended, but the Men-B is still not. Some countries have it, and some still, for the DHA, it's still not there. For those with asplenia, 2 doses, as we said, for the Men ACWY, and then 2 doses for the Men-B with 1 month apart. Advanced chronic renal disease, still not there. And for the health personnel, as we said, those who are at exposure risk, like the microbiologists. This is the American Academy of Rheumatology guidelines. And I'm not read all the diseases, but they've summarized it into the vaccines needed for those who are immunosuppressive, either by medication or condition, those who have inflammatory arthropathies, connective tissue diseases, any other inflammatory disorders. And you can see in the middle there is the meningitis, meningococcus B vaccine is recommended under the non-live attenuated, and the meningococcal ACWY. So it's recommended for all these groups by the American Academy of Rheumatology. So can we give the Men-B with other vaccines? I think this is a very relevant slide to the family medicine doctors. Because we often vaccinate, other conditions for HPV, for tetanus, for influenza yearly. So as you can see from the table, ACWY, can we give Men-B with the ACWY? I've mentioned that before. Yes, we do, but preferably different sites. So one arm and then the other arm. The pentavalent, if it's present, then we will not give the Men-B, because then the serotype B is already in the pentavalent, but unfortunately this one is not available in the UAE as of yet. Tdap or TD, yes, we can give them at the same visit, different sites again. with HPV in adolescents, this is very good time when we can combine Men B with the HPV vaccine, because a lot of us do recommend the HPV vaccine to the adolescents that we see. So we can add the Men B to it. How about the influenza? Definitely. Same visit, different sites. COVID vaccine, I don't think we do a lot of COVID vaccines in our clinics at the moment, so we'll skip that one. But it can be given. And as for the infants and the young children, yes, definitely can be given with their other routine vaccines. Can it be given with an inactivated and a live vaccine? If you're giving the nasal influenza vaccine, for instance, yes, you can. So lastly, I'd like to speak a little bit about other conditions where we might need to vaccinate. And that's when there is an outbreak. And God forbid we get an outbreak, and hopefully we don't. But this will shed some light about how to vaccinate in outbreaks and what is an outbreak of meningitis. So how do we define an outbreak? The CDC says an outbreak is when there's multiple cases above expected rates within 3 months in a community, or 2 to 3 cases within 3 months in an organization. The WHO and Sub-Saharan Africa uses other specific attack rate thresholds, like 10 cases per 100,000 in a week for larger populations, or the doubling of cases in smaller ones. So if you know the number in a small population and then they find that it's doubled, then for them that's an outbreak. Cases linked to travel to the Kingdom of Saudi Arabia, and because that's mass gathering, there have been reports of meningococcal disease and outbreaks who have traveled to Saudi Arabia in 2025, 2024. Threshold and vaccination triggers. Vaccination campaigns are triggered when attack rate exceeds 10 to 15 cases per 100,000 in high-risk regions like the African meningitis belt. Laboratory confirmation is important, of course, because we need to know which outbreak it is, which type it is, so we can address the right vaccine. So culture and PCR to confirm the serotypes and guide vaccine selection, ensuring accurate diagnosis and effective response. And there's always the surveillance, the work to be done before the outbreak happens, so they can predict if there will be any outbreaks. This is again the burden, and Dr. Mohammed had spoken about the burden in detail. But here you can see the African meningitis belt. They have a high burden, and it's mainly ACWX, and that's in 2019. A global 2.5 million. Again, all the A, B, C, W, and Y. And high-income countries, they have low numbers, but it's on the rise, and it's mainly B, C, W, and Y serotypes. So there's a rising incidence and affected group. Meningococcal cases are increasing in the US, mainly affecting adults between 30 to 60, and mainly in certain populations and those with HIV. Global epidemic impact. The African meningitis belt faces recurrent epidemics with high attack rates, stressing the health systems. Meningitis mortality, 250 deaths in 2019. 1 in 5 survivors will face long-term health issues like hearing loss. So it's the mortality rate is high, but also there is morbidity that is long-lasting with losing hearing, losing eyesight, and other disabilities. So what's the WHO roadmap? They have a roadmap for 2030, like they have with other conditions. So they aim to eliminate epidemics and have vaccine preventable cases. So they want to bring the number to half. and they want to cut mortality by 70% by the year 2030. So that's in 4 years. So what can we do within the first 48 hours if there is an outbreak, God forbid? Suspected cases receive intravenous antibodies promptly to reduce fatality risk before lab confirmation. Infection control practices, implement droplet precautions, so wearing the masks again, isolation for patients at least 24 hours after effective therapy, contact tracing. You go back and see, what school they went to, work, whatever, anybody was in contact, and giving them chemoprophylaxis. You have to identify at-risk contacts and provide them chemoprophylaxis within 24 hours of case identification. So really time here matters. Time matters and can make a big difference in the outcome. Community risk communication, inform. And we often see now that schools, not in case of meningitis, but like influenza or whatever, they send out some material, informative material, telling the parents, keep your kids at home or look out for these signs. Same thing here with the meningitis, if there were to be an outbreak. Again, case isolation, how does that help? It prevents further transmission. Antibiotic therapy reduces mortality and complications. Contact tracing identifies and protects exposed individuals. And chemoprophylaxis prevents secondary cases. So what is chemoprophylaxis? It's actually giving antibiotics. It aims to eliminate Neisseria meningitidis carriage in close contacts, transmitted and cause illnesses. So here comes the role in outbreaks to give antibiotics. What are the recommended antibiotics? Rifampicin, ceftriaxone, the ciprofloxacin, azithromycin, in case, areas where the ciprofloxacin resistance is there. Timing and effectiveness, as we said, must start within 24 hours of case identification. And the effectiveness decreases after 14 days. So it's useless then. Public health measures, ensuring timely access, overcoming barriers, educating communities, and monitoring resistant, reduce transmission, and support vaccination. So what's the role of the vaccine in an outbreak? Again, vaccines prevent outbreaks, reducing loss of life, health, safety, and livelihood, strengthen the global health security. Vaccine preventable disease, if you're sustaining vaccinating the community, then there will not be that many outbreaks. So what are the vaccination strategies during an outbreak? Choosing the right vaccine, depending on the outbreak. As we said, the serotype, you know what it is. You vaccinate accordingly. Mass vaccination campaigns can be done rapidly. Deployment of mass vaccination campaigns in outbreak regions. It's crucial to achieve herd immunity and stop disease spread. You have to watch for the cold chain and logistics. So the transportation of the vaccine has to be done in the right way, and monitoring vaccine coverage and adverse events ensures the safety and effectiveness of immunization efforts during outbreaks. So again, to summarize, early diagnosis and treatment. Now, needless to say, if there's a suspected cases, you don't need to know the serotype. You need to start therapy right away, as Dr. Muhammad showed us that, the disease in 24 hours can be fatal. So for the treatment, we don't need to know the serotype, but for the vaccine, yes. Outbreak management and prevention, collaboration and education, and advocacy for vaccine access and preparedness, planning ahead and to be online with the WHO's recommendation for 30-30 meningitis elimination targets. Just to let you know a little bit about the adverse events, and Dr. Muhammad has also showed a beautiful slide about that. The very common is the headache, the nausea, myalgia, arthralgia, injection site pain, including severe site injection pain sometimes is there, but most cases really it's just like any other vaccine. I have not seen anybody that I've given them MNB that came back to me with any adverse effects, to be honest. Again, the disclaimer is just as Dr. Muhammad said before. If you need anything, you go to the JSK products website, and they will help you with your queries. And thank you very much for listening.
Thank you very much, Dr. Mona. Excellent presentation. Very insightful. We have more than 400 audience with us. And we, as Dr. Mona summarized, early diagnosis, early intervention, early treatment, and vaccination. When WHO asked about their best preventive way all through the WHO history, it is the immunization. Because you protect, and Dr. Mona talked nicely about herd immunity, means that you vaccinate as much as you can, so you prevent disease transmission. They call it the solid immunity. So by this, I think we reached to conclusion. And if we have any questions from our audience, please go ahead. Islam, Omar, you would like to add anything from your side before we conclude?
Yes, Dr. Farghari, I just want to thank you and thank Dr. Mona for the conclusive and very informative presentation regarding meningitis. You have covered all the aspects about the meningococcal disease, and it's really important considering the increased number of reported cases worldwide. It's very important to be vigilant when it comes to diagnosing and making sure that those patients are diagnosed and managed as soon as possible, according to what you have shared, doctor, that every 8 hours the case progress dramatically. So this is the main message, and thank you for covering all the aspects when it comes to the meningococcal disease. And of course, thank you for the society for hosting and managing all the event from different angles regarding meningococcal disease. Thank you all.
Thank you very much, Islam. Dr. Mona, thank you very much for your presence with us today. I know you are in holiday, but thank you for sparing the time for us to give this beautiful, excellent presentation.
Thank you,
Thank you,
Dr.
Islam.
Muhammad.
Thank you, Omar. And I would like to thank all our audience for their attendance with us. And I hope we give the message clearly related to the importance of vaccination. And best of luck. And thank you very much. Thank you, JSK, for sponsoring this night. And thank you very much for the Emirates Family Medicine Society for endorsing this event tonight. Thank you very much and see you soon.
Inshallah. Thank you. Thank you.
Thank you.